Oh, okay. Is it busy on the roads? Oh, yeah. Friday, right? Anything that could happen on during the week, it takes a pause and happens on Friday, just to keep us on our toes.
Cornelia, I was
Yeah.
reading about. I was just reading some stuff on the weekend before now, and I really liked one of Louis Pasteur's quote. It says, "Microbes win every time."
They do.
Isn't that something?
You wouldn't think they do, right? But they
Yeah, I
do.
know.
Yeah.
Yeah.
In the end, they're always the winners, however you turn it. But it's a good quote for sure. They do win. Hopefully, we do learn something from it and we win some battles too, right? Hello, how are you? Hi, Karine.
I was the one who just spoke to you, Cornelia.
I just figured so much. Like, who was I talking to? Wasn't that her? Like, I better not say anything. Just go with the flow. That's okay. You know what? It's we have weeks when we are busy, and there are weeks when we have some time to catch up. The just make sure you do go through before your exam. So a couple of you guys emailed me asking me. So if you go into our calendar, do you guys see the calendar? I guess that should be the first question I ask. Do you see when you go into dashboard? Do you see the calendar? See if I can share. Yes. So you do see on the calendar the when is your exam scheduled, right? I didn't remove it. It's still there. Let's see. So here's your calendar. So I will open it on July 9th and I will keep it open until July 18th. So everybody can have a chance to enter and spend some time writing that amazing exam. Okay, so that week before, that's the week 8, that's when we have our break. So, and then we'll have, after week 8 is done, we'll have towards the end of that week, I'll open up your exam and you can write it. I'm curious. What did you think? You saw that was gone from the page. Um, so that's where we're gonna go in a couple of weeks. So just make sure you start reading, and if you have any questions for me, then I'm happy to help you through. Hi, Vernette. I was wondering where you were this week. I haven't heard much from you.
Hello.
Hi.
Oh, okay.
How
Just
are you?
checking. I'm good. I'm good. I'm good. Oh, you look like a queen today.
I am the queen.
That's
So
great.
Amandeep was asking me, where is my hat? And I said, Leonard said we have a visitor, and I promised I will be on my best behavior. No poop hats or poop
Oh,
headbands. And then because Amandeep was asking, I thought, let's just put a crown because I think anyone can relate to that.
yeah, that's beautiful. Beautiful.
So I was also showing my little magic wand that makes all the HAIs go away. All right. Leonard is here. Leonard, do we have our guest here? Let's give people a couple more minutes to sign in, and then we can start our beautiful journey of healthcare associated infections. So I see you guys all participated in your week 4 discussion. Is there anything that stuck to you that you were just absolutely mesmerized about COVID or SARS or Ebola?
I didn't even get a chance to come online this week. It was
I
chaotic.
noticed you were missing, just so you know. I noticed. No,
It was very
Leonard,
chaotic. Sorry.
no, it's okay. So, did you manage to talk to Cam about your book?
No, 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 not yet. I have a girlfriend who just did it, so she has one.
Perfect. No, Leonard, you scared me about the nice person coming and visiting us, like some serious person. So I thought I will wear my crown today. For the rest of the group who just joined in, Leonard was telling me we have a visitor today. It's gonna be observing how our recording is going. So I just thought I will not scare the poor soul away from right off the bat. So let's give them some intro, and then I will take out my poo hat and my poop hat band. Thanks, Anika. I am the queen of the third island, indeed. All right. Okay, let's get started. I think we are signing up on close to what is our average. So I'm gonna, this week we broke down into 2 sessions again because I think this particular topic does require a little bit more of our discussion and time spent together discussing some of these interesting bits and pieces of IPAC program. Everybody who is working in IPAC or is working in any sort of healthcare facility is very familiar with the terminology. We will just go through and get some around some definitions and talk about some particular examples, okay? So today we are gonna take it, the first piece is gonna be healthcare associated and some of the community associated infections. And tomorrow we are gonna focus on routine practices and additional precautions. So you will see that in our course, the they calling it set as nosocomial and community associated infections. Terminology has evolved and we are no longer calling them nosocomial. That's old school. So they're called a little bit different. So I try to change that to reflect as well. And so today we will be talking about a little bit about the transmission and the chain of transmission. So you will see, we'll touch on the chain of transmission. I have uploaded the link to a presentation from PHO that is broken down the chain of transmission, and Leonard is going to be working eventually on our the chain of transmission that I shared apparently requires some coding and decoding, and that's way beyond my expertise. So I leave that to Leonard to figure out. And then for tomorrow, we will talk about routine practices and additional precautions and break it down a little bit more in detail, and also talk about some of those infection risks and how do we control the transmission of microorganisms in our healthcare settings. Hi, Sharon. Thank you. So we already have mentioned this at the beginning, that the term nosocomial, it actually comes from the Greek word, which means a disease, and then comion means to take care of. So when we start looking into these nosocomial or healthcare associated infections, it is more or less the same thing. It's just a little bit more up to date and with current times. So the healthcare associated infections is a term that relates to infection that is acquired either during the admission into the healthcare, or it could be also contracted through the previous admission, and now the patient has returned to either our facility or has been admitted to another facility, and based on the incubation period and calculations of that, we can determine whether a disease or illness is actually healthcare associated, and whether it's attributable to our facility or the other facility, or could be also community acquired. Okay. So what is important to highlight here is the number of cases that we encounter in Canada. So this is a little bit older stat. I have some fresher stats as we go through. So you will find that this is probably one that you will come across most frequently. And it tells us that in Canada, 1 of every 9 hospitalized patients actually end up with healthcare associated infections. The cost, I do believe, has evolved quite a bit. We will see that a bit later in the presentation. And it ends up with about 8,000 preventable deaths. So I think for us as practitioners, this is what we should be driving home as a messaging, that this is something that is preventable, and we can all put our heads together and come to find solution and prevent these deaths from happening. So there is another section that we have to cover later on. It's in week 9, if I believe. It is actually completely focusing on surveillance. How are we doing surveillance? How is surveillance to be implemented as a part of IPAC program? What are the ways and the steps to complete surveillance? And what is IPAC's involvement? Hello, developer. All right, so we'll just be on our best behavior, not embarrass ourselves here in front of our developer, and hope that they get to help us with all the challenges that we are facing that Leonard hasn't fixed for us already. Okay, so surveillance is actually defined as an ongoing systemic collection, analysis, and interpretation of evaluation of health data. So So what that means is actually it is an ongoing process. So for most of us, it is bread and butter. You show up in the morning and the first thing you do is you start reviewing the data that's been collected for us. And often it comes through either printing on our printers, or it comes through emails, depending on how certain labs are set up to distribute that information. It also depends on what kind of facility you work in. So it's one part is receiving the information. The other part of that is really important for us is the interpretation and analysis of the information. So what do we do with this information that we receive, and what does that mean in terms of the case management, reporting, where does this information go, and what is the significance of the information that is become available to us. When you're looking at surveillance, it is actually an organized component of programs. So you can't really have it kind of willy-nilly going around putting some information. So you have to set on some definitions, and whatever definition you decide to settle on, that's the definition you want to follow through the entire process. So if anything in your definition does change, you have to calculate that in and bring that up in your further reporting. So when you're producing reports, and if the definition has changed, either because it's been dictated and mandated by the ministry, you highlight that and identify the time or the point of time that the definition has changed, and how does that have affected your data. So that's pretty much about a little bit of surveillance. Okay, Leonard, am I supposed to put my little poopy hat? Okay, I'll do it. Hold on. I think Leonard was telling our developer that there is a presenter and instructor that wears poo headbands. So now let's not cut that. Okay, everyone sees? Good, perfect. Back by popular demand, the headband with poop. All right, let's move to the next slide. So what are the elements of surveillance? So it is important for us to be able to detect any sort of challenges that may come up. So that could be either you have MRSA cases that are on a rise, or you have influenza cases that are on rise. You want to be able to detect them and also monitor development. For us, it's really important to know where is our facility sitting at in terms of baselines. So once you have a firmly established um, surveillance system, so if you guys had a chance to take a look at the line list that I uploaded for you in the last week discussion, you actually can use that line list to create a very easily visualized information for you to see whether there is problems and are our numbers on a rise or not. So that way you can determine if there is anything to be concerned about. That said, for any outbreak calling, you still have to go through calculation of your rates to completely have a full picture of what is happening, what's been happening in the past, and whether you actually truly are facing a problem, or maybe there is nothing to be concerned about. So once we collect the data, whether we're looking to identify who are our patients that have been testing positive for either colonizations or infections. We are looking also at the population. So is this a population that's at high risk to acquire healthcare associated infections? And also looking a little bit at the broader picture, is there any practices that may contribute to acquisition of healthcare associated infections? So usually you would be looking also at some of the clinical presentation, such as indwelling catheters. So usually that you will find often mentioned in surveillance of ESBL cultures and in facilities that actually do isolate only for the clinical specimens, so that's often mentioned. And also use of antibiotics. So most commonly you will find that this is mentioned in cases of CDIs and things that do actually change that equilibrium in the host after the use of antibiotics, and what are the outcomes. And also looking at chronic conditions such as your patients that may be on dialysis, or your patients that may be chemo patients. So there are some of these services that are provided that themselves in by nature put your patient at risk, but also the clinical picture of your patient. So we also want to make sure that we do evaluate our preventative interventions, and that we do have ability to provide information to ensure we are using the gathered information from our surveillance to form decisions, and we can use that information to educate our colleagues and reinforce the practice. All I can read is this post that Sharon posted. There is, she says her husband is working at HRH, and all I'm thinking is Her Royal Highness. I don't know if that's crown has affected the way I'm thinking, but I'm stuck with Her Royal Highness here. All right. So when we start looking into our own facility, so if you're looking back in week 2, I believe, is when we were setting up our week 3, when we were setting up our program. So part of our program is surveillance component, and it's, you can't have a successful IPAC program without a surveillance program. The way your surveillance program works, I always think about us as hamsters on this perpetual wheel of movement. So it truly never stops. It can only change shapes and can change the way you're focusing and redirecting your focus, but you should never stop your surveillance. So you always want to make sure that you are in a position that you're considering your population that is being surveyed. So you want to be able to break down by either it's a pediatric population or surgical population, or your continuing complex care program, and you don't want to mix those patients. So you have to have a good relationship with your probably your finance department would have a lot of information in terms of patient days and such, but for us, you can take all that information from your census. So if you are printing out your daily census and keeping track of where your patients are, some of the systems have ability to pull back your census a month, 10 months, or a year, even sometimes even longer, to look and review your cases in retrospect. So that's where it's important to know that you're not mixing your populations. Some of your patients will by nature also move through the facility. And so you may have someone who came in as a medicine patient, ended up as a surgical patient, and then a couple of weeks later ends up in rehab department, for example. So you always focus on this particular infection at the time of either presenting itself or the time of a swab. We'll talk a little bit about that a little bit later. So also, you want to make sure that your surveillance program is standardized and that you use validated case definitions. So I mentioned that a little bit earlier. So you always stick to the same case definitions. So that usually you will have them provided by either your local health unit, by your ministry, So you want to stick to those case definitions. I also find that across the board, they're more or less very similar. I don't find any discrepancies when I look across the continuum of the healthcare that there is difference in the case definitions. So they're usually based on the symptomatology, the incubation period, and so from there on, they set these case definitions. During the outbreak, you may want to take a look at some of the symptoms in specific populations. Your symptoms may not be always the book case scenario. So you want to touch base with your local public health unit. So sometimes you will see that from there may be a deviance from the standard case definition, and they will tell you, okay, so we are looking at, instead of having fever and cough and shortness of breath, they may say any elevated temperature and any change in respiratory status, or any change in appetite, and anything that would affect certain populations. So they will actually tell you how to monitor for any changes in certain populations. So always, as I said, always use the same case definition. So don't change it in the middle of your surveillance process, especially if it is during the outbreak. If your case definition tightens during the outbreak, you want to go back and review these cases that you might have missed. Sometimes you will still miss them, and these people may be discharged by this point, and that's okay. But just make a note in your reports that at, say, June 18th, we met with public health, and based on their assessments, it was suggested to us to tighten the case definition, and from there on, you're continuing with surveillance with the new case definition. So you want to make sure you are able and capable to use the information that you now collected to calculate and analyze to get your rates, because the rates are the ones that will be dictating in what direction your either outbreak is going or your annual surveillance is going, which may actually be driving some of those outcomes. And it could be also part of a major program development for your facility based on these rates. So you want to always be confident that your numbers are bulletproof, that you've done everything, and they're not budging no matter what happens. So how are we going to be able to, what are you going to be able to do with these numbers is to further on look at your HAI rates and interpret that. So you may be invited into some usually senior team meetings, senior leadership team meetings, or even if you are presenting to your IPAC committee, or if you're presenting to public health these numbers. So you have to be able to interpret what these numbers actually really mean. So what does it mean that you're extending your outbreak for however long, or does it mean that now there is maybe a new procedure that's been happening in your facility that is driving these numbers up, and you want to be able to find a correlation with either practices that you're bringing in, and you hopefully are bringing the numbers down of your HAI rates, and say, so these are the practices that we have implemented, and now we are seeing an improvement, or there is a new procedure that's taking place in our hospital, and we have been monitoring, and we are seeing an increase in, say, MRSA, and this is a bit of a concern for us, so we would like to put on hold. So when you're making any recommendation, you want always to support your recommendation with your numbers from your surveillance. So you always want to make sure you are communicating these numbers. So you're not just collecting the numbers for the sake of collecting the numbers and you admiring your beautiful charts. There is always a meaning behind it. So we as IPAC, we tend to report in multiple directions. So usually you would be reporting to usually to your senior leadership, to your direct managers, to public health, to ministry as well. So For in Ontario, for example, we do collect the information and send it to Quality Ontario. And also you want to go back to your own team and also to the units. So when you're coming back with these numbers, what does that mean for them? And how are they going to approach the problem that they may be facing? What does that mean in terms of the measures that need to be put in place? And also, once you reach the goal that you were hoping for, always go back and close the loop and report with the positive outcomes. All right. So there are your components of surveillance system. You will find it's like, I find this site a little bit too busy, but it's just all your components are on the same page. So and it's going straight back to what we discussed. It's assessing the population that you're surveying, selecting the outcomes for surveillance. So whether you're looking into your hand hygiene or VAPS or urinary tract infections, so those are your outcomes and what you want to achieve with these numbers. You also want to go back to establishing your case definitions, and I can't stress this enough, to remain consistent across the board. And the next component would be collection of the surveillance data, of course. And we are always expressing our numbers in rates. So we wouldn't say, oh, we have a case. Well, we would say we have a new case, but when you're reporting it, you're always reporting that and expressing it in rates. So it could, depending on what are we looking at, you could be expressing it as 100% or per 1,000 patient days. So that we'll get to that a little bit later in unit 9, and also in unit 8 we will be focusing a little bit more on the way we are collecting information and how are we processing these numbers and what numbers are we expressing the findings in. And then, of course, calculation, of course, and interpretation of your infection rates are important, and communication. I think out of all the things that we do, if we don't communicate what we have gathered and found out, it's really pointless. If we don't share what our findings, that information is only for our use and has little bearing on what we have if we don't share that information. So these are the measures of frequencies. So I'm just gonna make a little bit of a pause here and let you know that you have to know these. So if anyone wants to take a screenshot or you want to write it down, take your time. These are important. It's going to be, I'm sure there's going to be at least one question in regards to these measures of frequency on your CIC exam. We had a brief discussion about some of the terminology in previous week, but as I said, we are going to go a little bit more in depth, and I'm expanding and opening these doors to you so you get comfortable with terminology once we get to a place where we are taking a deeper dive in the section of epidemiology, which covers predominantly statistics and then surveillance. So rates are expression of frequency in which an event occurs in a defined population over a period of time. So when you're looking at your rates, so you're looking at usually your attack rates. So you can say there is, we are looking usually with outbreaks or such, or any events that take over an extended period of time. So you would be looking into your VAPS, for example, would be expressed in rates, or your surgical site infections, and so on and so forth. So ratio is value that's obtained by dividing one quantity by the other, and then you're probably most comfortable with proportion. So that's usually a type of ration that values that in which the value is the numerator and includes also the denominator. So that's something that you will also be covering in next few weeks a little bit more. And then of course the incidence rates and prevalence rates, those are probably the ones that you will be asked few questions on your CIC exam. So the incidence is a measure of frequency with which an event occurs in a population over a defined time period. Numerator is a number of new cases where the denominator is the population at risk. So it's always, you're looking always at the new cases with the incidence rate in certain populations. So say if you had, you have a unit and suddenly you have new case of MRSA, but there is also cases that were already on the unit that came in. Maybe they were there during the month of May, but now you have a new case that is new healthcare associated case. When you're doing your rates, this is your incidence. So this is the new cases. So those are the ones that make you or break you really in terms of outbreaks. And then when you're looking into prevalence rate, so that's all people in a population who have particular disease over a specific point of time. So if you're looking into the same unit, now you're looking at all your cases of MRSA. So you're looking into your healthcare associated cases, your community associated cases. Everybody on your unit who has MRSA is actually used in this number, but you're looking at, say, for month of May or month of June. So you're still focusing on a certain period of time that these people have been present on your unit. So you're not looking at someone who has been discharged in April. However, if you had somebody during the month of May that have been admitted, say, May 5th, and then got discharged May 10th, you're still counting these people because they were on your unit in that particular time. All right, so now we are getting into the calculation. So this is incidence rate. This is the same thing I already said. Make sure you're very, very comfortable with these definitions. I'm 100% positive you will have these on your CIC exam. So incidence is always a number of new cases. So and it is calculated in over 1,000. So you're always multiplying your final number with 1,000. And then in your prevalence, it's the same thing. You're calculating that the number of all existing cases, divide that by the number of population in the same period, and then multiply that by 1,000. So I give you there an example. So you can actually do your little calculations. So on a unit of your Blossom Hospital, not Her Royal Highness, there were 4 positive cases in June. 2 of these cases were healthcare associated during the month of June. What number would you use to calculate the incidence rate? And what number would you use to calculate prevalence rate? Oh, sorry. So let me see, what are you asking? So with regards to your exam, you should allot minimum of 3 hours for that exam. Sorry, I keep missing your question. You keep asking the same question again and again. Sorry, yes. Yes. Very good. So is everyone in agreement that for the new cases we are counting 2, and for the all cases we are calculating 4 cases, right? Agreed. Okay, let's move along. So for your attack rate, so that's a little bit a different rate. So usually we use these during foodborne illnesses. In community is probably the one that I would think of as a quite common used way to calculate the what is the true scenario for us. So I can say, oh, there are so many people, so many ate, but until you actually calculate your rate, you can't say whether there is a problem. So attack rate is a proportion of persons at risk who became infected over an entire period of exposure. And it's expressed in hundreds, so it's percents, right? So it is a number of new cases over a population at risk during a given time period, and then you multiply that by 100. So let's just imagine a case where a foodborne illness outbreak has occurred among IPAC class. So we all got together and we had eaten some food. And 12 of us have eaten a potato salad. 4 of the 12 have developed a foodborne illness. How do we calculate this attack rate? So your numerator in this case would be the 4 ICPs that ate the salad. Exactly. And then you divide that by people at risk, right? So you're not calculating the entire class, which is now 27 of us. You're actually looking at people who ate this particular salad and then who are the ones who got sick. So some of us may have been smart enough and said, I don't want to eat any potato salad today. No, doesn't look good. Not that we would know, but anyway, so that's Sharon shared a number down there. So it is a 33% is attack rate. So when you start looking into your rates and looking at the numbers, so what is really important for you is to take a look at the risk stratifications. So a couple of things that I can think of is your surgical rate. So you always want to make sure you're comparing as I say, they're apples to apples and oranges with oranges. So if you are looking into your surgical site infections, you always want to put your total knees with total knees and your C-sections with your C-sections. So it doesn't mean that just because it's a type of surgery that it falls under the surgical site infection. So there, even within the field of surgical site infections, there is a stratification based on a certain on a based on the site of the surgical site. So you're looking into your usually you can break it down also by facilities. So if you have a multiple sites, you can break it down by a site. You can also break it down by the unit. And also there is also some other stratification methodologies when you're looking into your you can break it down by gender, you can break it down by age categories, depending on what are you trying to achieve. But there is always a way to sort and sift through so you get cleaner data, and that's what's important. So if you're looking into, say, sometimes you have a risk from either a procedure and you know that Dr. Smith is your surgeon who is always using a certain type of equipment. So if you're suspecting that maybe that equipment may be a contributing factor, you would be only looking at surgeries completed by that particular surgeon. So because you know for a fact that he is the only one or she is the only one who is using either a certain type of equipment or certain approach to a surgery, so it's easier that way for you to navigate through the sea of information that is out there. So when you're looking also at determining available methods, so there is always that severity of illness index, your ASA scores. We will be covering that in a great detail, and I will tell you your ASA scores will be also on your CIC exam, so we will get into that in a more detail. Also looking into your methods, whether they're validated methods or are you coming up with something that is maybe brand new, and you may be brilliant and finding something new that you want to share with other people, but usually for your reporting purposes, anything that is being reported to any of our managing agencies, you always are looking at the set definitions and set methodologies. So when you start looking into your device associated infections, that is also a little bit of a different calculation. So you would be looking usually at the extended period of time. Usually you're breaking it down by either month or quarter or semi-annually or annually, depending on what are you looking at. And also you're looking at the volumes that your hospital is actually producing for you. So if you have one surgery that is of that nature within a year, there is not much you can do. So you're usually looking at these high frequency and frequently occurring surgeries on your in your facility. So you want to always look at your population again. So if I was saying for for your VAPS, right? So that would be your ICU population, for example. Or if you're looking into certain procedures or infections that are affecting your population, you're using that as a numerator. So you must be site specific. So I already mentioned to you guys this, if it's like, say if it's a cardiac surgery, you're looking into that particular surgery that is only the same surgery all the time. You're not mixing and matching different cardiac surgeries. So they also must occur within the same patient population. Or the other thing that to look at is also looking at your time period, right? So back to if you're capturing something that has happened in a period between 2017 and 2020, those are the events that you're looking at. So you're not looking anything outside of that set preset time frame. So you also want to look at your device days. So when you're looking into, say, catheters or VAPs, you're looking at how many days were your patients actually with this particular device. So if you had a patient, and it can be 30 patients on a unit that are spending their any particular time, you're counting for each patient each day, and that's how you're usually calculating your device associated infection rates. And then again, you're focusing only on a particular device. So if it's a UTI, it is a Foley catheter in, say, in your alternative level of care, and you're looking at say for month of May, or you're looking for a year of 2020, however many infections were related to use of catheters in this particular population, and then that's your time period. So that's how you count that, and they're always multiplied by thousand and expressed in such rate. So when we cover your surgical site infection rates, they're calculated for a particular type of surgery. I already mentioned that. Population at risk includes your patients who have the same type of surgery, and because of the low volumes that you're looking at, it's expressed in hundreds. So you're looking at number of infections, divide that by the number of surgeries that have happened in particular time period, and then you multiply that by 100. So Anita, I don't know that Leonard will be able to upload this so fast, but I'll let Leonard speak to that himself. So with your communication, it is important that we are sharing these findings, because if we don't share, if you find that there is anything that would need our assistance or work around the problems that you're seeing, you have to involve a broader team. So first of all, you want always to share information within your own team, but also in many facilities, you will have either a quality improvement committee or a quality person that is looking into the outcomes that may affect the patient satisfaction, mortality, and morbidity. And so you want to talk to these people and bring them up to speed to share your findings. And then, of course, you want to talk to your program specific team. So, if it's a surgical, you want to talk to your surgical team, to the surgical nursing team. You want to have access to these people as well, sharing your findings, and they may actually be able to help you more than we can only look at the numbers in terms of finding what seems to be a challenge here. And you also want to report your findings on regular basis. So most common reportings are coming out quarterly and annual. So that's usually how we report these things. So when you start looking into your epi curve, I think we had a brief discussion earlier, maybe 2 weeks ago, about our epi curves and how we're looking into our means and modes and medians. So that's when you're looking how your epi curves are going to be shaping up. So it is usually developed through your Excel spreadsheet. I really don't know many other ways. I remember way back when doing it on paper, but let's not age myself. So usually you will be looking into your Excel spreadsheet. On the front page, you are having your line list, you're putting in your dates, and at the back you can pull that easily through your pivot tables and pivot charts, what you're looking in terms of the new cases, the frequency of cases occurring. You can break it down by the site of the organism found. You can also break it down by the unit, so it helps you understand what is actually truly happening on your unit. I find anytime you can visualize an event, you have such a better understanding of any event taking place on your unit. So you also want to be able to determine whether your outbreak is a source, one event, or is it something that's propagated. So with propagated events, usually we think about things like foodborne illnesses, where you have somebody who has been exposed and now they have, say, for example, salmonella, and now they're working in a food premise, and you see that there was one isolated event or maybe few cases, and then you have, through that incubation period that's passed, now you have new spike. So that would be your propagated events. And then you're also looking into ability to review your case in terms of the time of exposure, and also in relation to the cases that could be a source of this infection. It helps you also identify your incubation period. So because we know from your literature what is an incubation period, but when you're looking in your own outbreak and your own event, you actually can determine what was the particular incubation period in this particular event. And also you can identify whether you still having a problem that's ongoing, or has it actually stopped with the measures that you put in place. All right. So there is an example of a common source outbreak. So usually, again, I'm thinking about your foodborne illnesses in this particular case. So you can see there is a common source that has actually happened on November 6th. There was one case, and then as you're moving through your chart, you see that you had additional cases that have been documented through through the period of November and December, and you can see that the peak was somewhere around maybe 27th, that we had the highest number of cases of your salmonella cases in this particular outbreak. So we'll see that this particular person was actually a primary reservoir, and then as they have continued to um, spread the goodness, you have your secondary cases and the total number of cases. So exposure can be continuous, and you can also have something like intermittent exposures. Those are a little bit harder to find because you see you have your peaks and valleys with these intermittent cases. But the first thing that comes to my mind is our lovely friend Mary. Exactly, just like her. So when we start looking into our propagated cases, that's you're looking into your continuous source that is occurring over extended period of time. So you will see that this particular outbreak started off somewhere in mid-October and it's carrying till January, mid-January. So usually when you start looking into these, this is your infections that are transmitted person to person, and they can't be attributed to a one single case. So usually we are thinking, when I'm thinking propagated sources, I'm thinking things like measles, for example, where there is one person and has exposed a number of different people who then went and exposed a number of different people. That could be also with your influenza or COVID. So usually you have these people that are moving around while they're symptomatic or asymptomatic and they're shedding, and we don't really, most people would stay home when they're unwell, but they go out and affect number of different people. And then you see in this particular case, you will see how the numbers are going up, and we reached a peak somewhere in, I would say, early the first 2 weeks of December is when we had the second peak, and then the first week of December was and then you can also tell what is your incubation period based on these cases that are actually happening. So where you have these gaps in between, that is your incubation period. Right. So let's start talking about the cost of healthcare associated cases. I shared this particular slide with you in previous lectures and it doesn't change. So it tells you that 1 in 9 Canadians will leave a hospital with a healthcare associated case. And it is actually in Canada, it's a fourth leading cause of death. So it's right after cancer, heart disease, and stroke. So if you're looking into these particular diseases with healthcare associated infections, something that we actually can control and it is within the reach, where for some of the other diseases it's a lot of the contributing factors are either genetics or the individual's lifestyles, where for HAIs it's usually we are exposing our patients to the environment and bringing it to them. So that's important to keep in mind when you're practicing, that a lot of things we do are preventable and focus should be on prevention. So, okay. So I'm going to give you guys a 5-minute break, a bio break if you wish, and then we can continue, come back to focus with two particular organisms, if that's okay. And if there's any questions that I've been missing, I'll answer right now. All right. Do we have everyone back? Yeah, I just want to make sure we don't have someone who is saying that they couldn't log in or something to that extent. So I want to make sure I keep my eye on emails as well. Okay, very good. All right. So for the most common healthcare associated infections, you will, I'm sure you have encountered, if not all of them, some of them. So, also when you start looking into the antibiotic resistance and the management of the microorganisms and use of antibiotics, you will see that some of these are repeating. So once we get to that lecture, you will find that some of these repeat offenders are on their list as well, and probably one that I would say is always targeted from all of us is C. diff. But let's start with our friend MRSA. So you guys know from the previous week what it is. It's a Staph aureus. It does have ability to cause foodborne illnesses. I know I grossed out Sharon last week with it. And it's in about 60% of general population carries it on their skin. However, once you start looking into your MRSA cases, then these numbers are actually a little bit lower. So that's kind of important to keep in mind when we are talking about Staph aureus. It is a part of normal flora. The issues arise when we start looking into our methicillin resistant types of Staph aureus. Quite commonly, it is present on the skin. However, when we start looking into swabbing certain surfaces, we are looking into either nasal swabs or perineal swabs. You also may be looking into the wounds. So next week we will be addressing a little bit in depth on how are we collecting these swabs and how the wounds are being collected. So we are not getting any gunk that is not a part of the flora that we want to investigate. So as mentioned, your Staph aureus is part of your normal skin makeup, so that makes it a potential pathogen. So when you have your wound infections or bloodstream infections or pneumonias, that's when it becomes pathogenic in nature. And it's quite common actually in the healthcare facilities in healthcare settings. When you're looking in terms of transmission, it is transmitted through contact. So it could be either, in some cases, you will find that people will self infect. So if you are a carrier, you may end up with either, if you're touching some of those pores and with dirty hands, you may actually introduce that MRSA into bloodstream yourself, or it could be something that us as healthcare providers are introducing during care due to lack of hand hygiene or use of contaminated surfaces. So when you start looking into the methicillin resistant form, we mentioned this before, it was one of the first antibiotic resistant organisms identified. So it's not something that we're dealing as of recent years. So it's been around as early as in during the early as 50s, and that's what actually propelled the development of IPAC programs back then in the facilities. So people were fighting infections that are caused by this particular organism and saw the need to develop and create infection control programs. So I guess we can thank this little guy for our careers. So thanks, MRSA. It is more resistant than your Staph sensitive Staph aureus. So you want to make sure that when you look at your reports, when you're getting any sort of a lab result and they're reading your Staph aureus, most of the labs will tell you right away in the heading that is methicillin resistant. However, if you're looking into your susceptibility, you want to take a look at whether it is susceptible or resistant. So But as I said, most labs reported right away to you, so you don't have to go through the sensitivity report. Once you start looking into your methicillin resistant strains, it's a really hard line now to tell which one is. Did we bring Staph aureus into the facilities, or are we growing our own within the facilities? Because it's been so prevalent in the community. You will find them quite commonly in gyms, in spas, and there's outbreaks that were linked to those the covered soccer fields where they have plastic turf. That's where it's been quite commonly linked. Um, Quite often, you will find young athletes that are being actually diagnosed with infections with MRSA. And again, due to close contact, sometimes some of that equipment is impossible to clean, so it just gets contaminated. And with the environment that is rich with moisture and some of the skin residue in these particular outfits, you will find that some of the athletes will have skin infections that are caused by MRSA. So it is transmitted through contact. So there's when you're looking into the contact transmission, most common modes are direct or indirect. So your direct contact would be uh, an individual touching another individual. Usually it's depicted as handshake, but it's more than that. So in a healthcare setting where we are very hands-on when it comes to our patients or residents, it is absolutely critical that we clean our hands. Where I find we are not so great is the comprehension of use of gloves. So often people will say, "Oh, I'm wearing gloves," but they're really not replacing these gloves in timely manner or cleaning their hands after they're removing the gloves, so that contaminated glove does travel from point A to point B, causing trouble to us for us. When you have a case of MRSA, identified. So sometimes we are lucky enough that we know that either a patient or resident on admission is coming and we have history of their previous colonization or previous known history of their infection. So we know right away, so this particular individual, Leonard, is coming through. Leonard has been colonized for many years, so we are putting Leonard right away on contact precautions, making sure Leonard has a private room. Everyone coming into the room is wearing appropriate PPE. We are all sticking to hand hygiene because we know Leonard's been with us for many times before, and we know how to manage this. And as soon as we place Leonard in one of the patient's rooms, we put the signs on the door, contact precautions. Most of the signs that we are looking at have the appropriate PPE on the front, and then usually at the back you will find the ways of how to don and doff this particular PPE. And then also comes down to the cleaning of equipment. So once you have a patient that is placed on additional precautions in some systems in the hospitals, it automatically pushes these reports to your housekeeping supervisors, so they will know room 11 on the third floor of the medicine unit, that is a room that needs special cleaning. They will not know that's Leonard, they will not know what Leonard has, but they only know that there's additional precautions and what type of cleaning they need. So there is some of that information that's being shared a little bit more in detail with our supervisors, housekeeping supervisors, and you may be on that distribution list where they're communicating to their staff. Sometimes we will ask specifically for additional cleaning of some of these rooms based on what do we know about the microorganism that this particular individual has. And then quite typically we limit the movement of these patients. So if you're dealing with somebody who is on additional precautions, we would usually say no leaving the room unless medically required. So these patients will go to rooms and units with a higher level of care or for diagnostic imaging. However, no visits to Tim Hortons or no visits to your cafeteria or what have you, unfortunately. Things are a little bit different when you are looking into your long term care facilities and retirement homes, because you simply can't lock up a resident and throw away a key and say, well, tough luck, you have MRSA, you can't leave. But for most situations in acute care settings, and because of the risk associated to transmission and acquiring potentially an infection is much higher in acute care setting than than in long-term care facilities. So yes, visitors are usually allowed depending on what are you dealing with. If it is MRSA or VRE, usually we before COVID, of course, we were allowing visitors. Granted, we were providing education to these visitors. Um, some In some instances, when your patient is on additional precautions, it is not wise to have visitors. If it's something that is highly communicable and can put your visitor at risk, you don't want them to be hanging out around the patients that we know are highly communicable. Like I'm thinking about things like measles or chickenpox. So, and in that instance, again, you have to take every case as an individual case and assess it as such. So you may have a young child and you don't want to cut that relationship and contact with the parent in this particular instance. But also at the same time, you also have to think about who is coming. And then when you are teaching, I think what's really important is to be very careful with information that is in our possession. So if you're educating a visitor, you don't say, oh, you know what? So let's say Aisha is visiting Leonard, and you don't want to say to Aisha, you know what, Aisha, Leonard has MRSA, so this is what we do. So we don't share the diagnosis with the visitors. First of all, we have to make sure that the patient is aware of their status. So you're not breaking news to the patient, you as a practitioner. Then the second thing is also, because we are in the circle of care and we do have access to a lot of information, it just doesn't provide us with liberty to share that. So we have to be careful who and what are we sharing that information, who and with whom are we sharing this information, and what is the information. So if you're teaching a visitor, you want just to make sure, say this particular patient is on contact precautions, this is the PPE you're wearing, this is how you are putting it on. They will see the sign anyway what it is, but you don't put on Leonard's door, Leonard is MRSA positive. You only put a contact precaution sign, which covers an array of different microorganisms that are transmitted through contact precautions. So even in terms of their family, this is not something that we don't share the diagnosis. So it is a physician's responsibility to share that information with our patient. Once we know that the patient is informed, then we can go in and provide the education. But we are not the ones to share that information with the patient as a first contact. When it comes to family, you either will check in the chart if that particular person is permitted or to know that information. And if there, sometimes it happens to me when I'm teaching to providing education to the patient, the visitor will show up, and I ask them if they're comfortable with sharing that information with their visitors. It does simply happen sometimes that way, but ideally, you don't want to provide diagnosis to anyone. This is not our role. This is for the physician. Sometimes nurses will share that information, but ours is to provide the education around it. So usually how it works is a nurse will give you a call and say, you know what, Leonard just found out he has MRSA. He's really, really concerned. Can you come down and talk to him? Or Leonard is going home and his wife is concerned about laundry, or how does she clean dishes. So you would set that time because you're already invited, and you know from that type of conversation that everyone is in the loop. So does that give you an answer? Yeah, so we don't we there is no recommendation for like MRSA or VRE or C. diff for the people to remain isolated, because they're likely, very highly likely, is that they are coming to us already with something that they acquired either in community or had it previously. If it's something that's new, of course, they have more questions and more concerns. But generally speaking, it is not something we are saying now they can have a normal life as they move through their life with either MRSA or VRE. When it becomes a little bit different in terms of information we are sharing with our families and our patients is with regards to CPE and C. diff. So we usually ask if there is ability that they can have designated washroom after they're going home, simply because of the transmission of C. diff. Um, and if they can dedicate that washroom to them. There is nothing really to do about the laundry. Laundry just gets laundered as it is through your normal laundering procedures. We are not advising anyone to throw out or use disposable dishes. Simply, we are not using it in our healthcare settings either. So there is no risk as long as you're doing your cleaning and washing and sanitizing through, so you're fine. And it's not something that is something that is really concerning. So if they can't designate a washroom, you you can always ask them to have cleaning products readily available for them to clean after they use. So that would reduce the bioburden in the washrooms. Okay, no problem. Okay, so let's move along. So we are moving now to VRE. We kind of had talked about it in last week quite a bit with regards to isolation practices and how Ontario had a little bit of a hiccup over past couple of years where we've seen hospitals stop isolating. It is a contact precautions. It is a contact transmission. It is usually, again, direct or indirect contact. When I think of VRE in comparison to MRSA, I always think about VRE in terms of contaminated surfaces. Yes, they both do travel on hands, and they both do travel on surfaces. However, VRE being a fecal contaminant predominantly, think about the feces itself and how it is quite rich in lipids, and it's really hard to clean surfaces and has a tendency to remain on a surface. Not because of the microorganism being able to survive on the surfaces such as C. diff, but more to the nature of the organic matter that survives in. So usually we say good cleaning with a good surfactant, and your regular disinfectant, like regular hospital grade disinfectant, will do. However, because we know it's really hard to clean these surfaces, often we will advise to bring bleach or accelerated hydrogen peroxide, just because they have a higher ability of breaking down the fats in the feces where VRE is. And also with some of these, the equipment that gets contaminated, it's very often very sensitive equipment, and it's not to be exposed to harsh chemicals, so that becomes a challenge of cleaning. Again, once a person comes to us with VRE, or we test them and identify and discover that this is a new VRE case, we make sure these people are placed in private rooms if ever possible. When you don't have a private room, you can cohort, but it's really important to know that, again, what type of VRE are we dealing here, because you can have Enterococcus faecium and Enterococcus fecalis, then you want to make sure you're matching likes with likes. A lot of people will say it really doesn't matter, but just to be on a safe side, because of these jumping genes between all these microorganisms and ability to develop more resistance, I would say if you can, always dedicate a private rooms to them. If not, cohorting is an option. It's not something, again, that is impossible to control. We just have to be super diligent with our PPE, making sure that we are replacing PPE between the patients when we are providing care. Sometimes we would advise also to assign different nursing teams to these particular individuals, so that also reduces that risk of cross contamination. Hand hygiene, of course, is always critical. There is no question about it. But when I speak about hand hygiene, I don't think just about your 4 moments of hand hygiene. I also think about usage of gloves and cleaning your hands appropriately prior to placement of gloves and after the removal of gloves. Again, we put a sign on the door, and then with cleaning, it's communicated to your housekeeping. You don't tell Miss Mary on the floor that now Leonard, poor soul, not only does he have MRSA, now he got VRE. So we're not going to tell Mary that he has all these bugs. We just tell Mary what type of cleaning is required. And so she can actually get maybe from your cabbage side or what have you, or any of your regular housekeeping cleaners, disinfectant, to the next level, your either bleach or accelerated hydrogen peroxide. Again, focusing on equipment, making sure that is properly cleaned and disinfected. And it's of critical importance that we do remove that organic matter and then provide the second um, repeat wipe of disinfection and allowing for the contact time. And I think I think it's important that we know what's the contact time and we are sharing that information. So some of the situations you may encounter is people like to rinse after use of, in particular, bleach, because bleach breaks down into salt and water. So water evaporates, of course, and then what you're left on the surface is the salt buildup. And that salt can be quite corrosive, but it's also very unappealing if you're looking at surfaces that have that almost it looks like Canadian roads really in winter. And to be quite frank, I really like to see that. I know when I see that there is that salt buildup, I know that it's being properly cleaned. It doesn't bother me, but I know some people don't like. So it is possible to rinse that off with water alone. However, you have to make sure that we have achieved that contact time to kill the microorganisms. And the same thing goes like with Leonard is allowed to have his visitors, and we don't want him to suffer any more than he already is, but we have to control also who are the visitors and whether they're able and willing to follow the instructions. So that becomes a bit of challenge for us when you have families bringing young children. So some of these kids can follow the instructions, but usually your visitation policies actually will spell out at what age are they comfortable having children in the hospital. Sometimes that cutoff is age of like 12 or 15, depends on what the facility sets on and settles on. But if and that becomes a challenge. So sometimes some of these cases are, again, as I said, one by one. You have to meet with the families and provide education to them, and sometimes we are asked to accommodate due to extenuating circumstances to accommodate. It really is not our role to say yes or no. We just provide that education piece to anyone who is permitted to enter. Usually, that decision would be sitting with the unit manager or patient's relations. So, those are the people who will make those decisions for some of these. Exceptions, but we come in and provide education to these individuals. With VRV, what's really important to make sure we know what's the status of our patient in with regards to their continence. So, are our patients able to, are they cognitive too, and how are they managing? Sometimes in some cases when we are dealing with some advanced dementia or mental illnesses, you will find that containment of fecal matter becomes quite challenging. And in a patient who is colonized with VRE and has additional challenge of managing their own stool, or if they're maybe incontinent and the brief is not always in place, so that becomes a higher risk for us to manage such case on a unit. um, Also, in some, there is also a possibility that we are not coming across quite clear. That could be due to poor communication or misunderstanding. Maybe we are speaking in too many technical terms, and also there is always a language barrier, a possibility that is a cause for misunderstanding. So, so Beth here is saying we are seeing more and more AROs in long-term care facilities, and with contracted housekeeping staff, few private rooms, it's a very challenge. It's very challenging. So yeah, so I can see a couple of things that come to my mind. Um, I've been in facilities that we had a third-party housekeeping companies, and I've been in facilities where we had in-house housekeeping. And it may be just that is my experience, but we had amazing experience with our third party cleaners in our facility, and probably the best of any I ever worked with. And because their contract really dependent on satisfaction of IPAC team, so we were, every time their contract was up for renewal, we were always asked to weigh in. And we had amazing relationship with this particular company and their team. So the staff, in fact, was the frontline staff was hired by the hospital. However, the management was externally hired. So really their jobs were more dependent on our assessment than anything else, and was really important that they're hitting all the marks that we are asking them for. In other facilities that I worked in, I found it is quite a challenge dealing with a lot of that internal housekeeping. And it's always when you're looking into budgets, and the reason for it is strictly budgets, because once the budgets get to be cut, there those are the teams that usually get hit first, unfortunately. And you will see that they're always short staffed and always running around trying to accommodate the movings of the patients, and there's always something else on fire that they're running to. Can anyone else hear me? Or is just Uganda having a problem? Okay. So I think it's just Suganda that has a problem. So let's see if she can log off and log on, and I will continue in same um, about the same topic before she comes back. Okay, perfect. So I think maybe it's just a connectivity problem. I know I spoke with Leonard about some of these issues. Usually it is one person that has a problem, and it sounds like it's a connectivity issue with either on your end or the quality of Wi-Fi. If you're on Wi-Fi, try hardwiring if you can, so that may help. But beyond that, I really don't know much. So Leonard can shed some words of wisdom with us, share some words of wisdom with us on that. Right. So we were talking about VRE and housekeeping. So also with regards to your increased ARO numbers, so maybe did you change something in the policy of surveillance? Usually you will see increase, of course, when you start looking, you start finding. That's one thing. Other things is also if there was any change in the labs. So the way the labs are running their specimens, or could be something to look into that. But as far as the housekeeping goes, um, they often do get the shorter end of a stick when it comes to budget, and you end up with a lot of problems with them. So something to take in consideration if it's becoming to turning into a true problem for you, and you are seeing that patients are being admitted into rooms, or residents in your case, that are not properly cleaned, or your marks are not hit on how your daily cleaning of high touch surfaces may not be accomplished, or keep track of that, or and then you need to have some evidence to actually bring that up to your senior management, because without that it will be hard for you to push for any change. So to support my point, what I said, whenever I think about VRE, this is exactly what I see. We tend to refer to any of the surface contamination as fecal veneer in a healthcare, and that's exactly what I see everywhere I go through any of the healthcare facilities. All I can see is these little red dots, except when I imagine them, they're not red. So I'll leave that to your imagination. So you can see that when you're looking into your patient room, there is these high touch surfaces, usually the foot of the bed, the bedside table, nightstands, the phones, TV screens, and then anything that is, you can also take a look at the curtain. Although curtains are really not something that has been a problem in any of the outbreaks, it's always the hard surfaces, because it's easier to lift a contaminant of a hard surface, hard smooth surface, than is from a curtain. So if you're looking down the corridor, you can see all the handrails and everything that we touch with our hands, doorknobs, or the sanitizer, which in this case is quite high. I don't think I would be able to reach this high, the sanitizer, but probably installed for all the tall people of this world, not with me in mind. So the next organism that you do see in your settings is ESBL. I will tell you that in my career, when I started working, everyone was isolating these, um, either based on being positive on as colonized, or due to infections. Most common organisms that you will find are E. coli and Kleb pneumo, and are quite frequently linked to UTIs. As the time is progressing and we are learning more and more, and finding more other competing issues and challenges that we need to address, ESBL kind of falls off really quickly off the isolation practices, because it is still, there is antibiotics we can use to treat. And with ESBL, we find that people tend to have a period when they're positive, and they are shed the organism, and they're no longer positive once they leave the healthcare facility. So there's some of these assessments that go in the decision making process. And so it would be the treatment, the risks, and what outweighs this risk. So usually if you have a CPE patient versus ESBL patient, you want to isolate that CPE patient or your C. diff patient, for example. So if your patient is on precautions, it is contact precautions. And same thing, you would have the signage, the PPE that goes with it. And as I said, predominantly you will find in most of the facilities, if they're still isolating, it will be based on their clinical specimens. And usually these precautions get discontinued in this particular instances is once the UTI is removed, sorry, not the UTI, the catheter is removed. So if you remove a catheter from ESBL positive patient, you usually we say you can take off the discontinue the precautions. Is anyone isolating out there for ESBL? No. Yeah. It's not, it's as I said, it's been kind of falling off the radar until something else happens in future, and then we have to just go back to square one with that. But right now, the trend is no isolation for ESBLs. When you're looking into swabbing your patients, it is a rectal swab, usually for colonizations, and you can be collecting a urine specimen as well if you're looking into patients that are maybe colonized in or infected in their urine. So that would be your clinical specimens. I have seen few bloodstream infections, not too many. I have never seen a lung pneumonia caused by ESBL, but it doesn't exclude it as a possibility. But it could be also surviving there in some of these situations where you have a patient that is intubated and such. So back to our good old friend, the carbapenemase producing enterobacteriaceae, or CPE. It is quite a development that we have witnessed in past decades. It started off quite as we don't have this problem. This is something that happens elsewhere, and we are only seeing imported cases. But things have changed, of course, over the course of time. What it is usually your E. coli or Klebsiella, and the mode of the sharing the carbapenems, the enzyme, rather, the carbapenem breaking down enzyme is they share a part of their genetic makeup. So what usually happens with them is they're very close relatives, bacterias, and when I'm teaching to the frontline nursing, I always describe it as Smith family. So I will apologize to Corinne and Crystal, but I described them as Smith family that are having a number of different family members. So there is David, there is Anne and Mary, and they got together for lunch. And then one of them actually comes in with information, oh, I know how to break down the carbapenems. And while they're sitting together at the lunch around the table, they're sharing the knowledge, which is in retrospect, it truly is that genetic material that travels between the microorganisms. So you can have E. coli sharing that information carrying genome to say Klebsiella or Citrobacter freundii or any of these large family members that are extended relatives. I apologize again to Corinne, but so that's usually how that kind of works in a simpler way of describing how this inherited knowledge is shared. Um, when you start looking closer into the CPEs, you will find there is different subtypes, and what is really important for us to know and keep an eye on is that we are growing our own. And I mentioned this before, it is extremely high mortality rate. It is actually up to 50% of your patients with infections will end up dead, unfortunately. So what happens with CPE in Ontario? I just want to show you some of the relatively recent findings that we what we originally thought, as I said, is that all of our cases are coming either from New York or India, or they're coming from these countries that have a higher rates of CPE, but things have changed. So if you're looking into the outbreaks and observation of outbreaks in Ontario in period between May of 2018, May 1st to April 30th of 2019, there is actually 350 confirmed CPE cases. So that does include both infections and colonizations. And 29 of these patients had over more than one organism isolated. So they would have E. coli and Klebsiella, for example. But and then when you're looking into your overall rate of CPE in Ontario, we are looking at 1.9 per 100,000 individuals in population. What is really interesting to take a look at is for these cases of 350 cases, there is two different species that have been leading, and you will see that's E. coli and Klebsiella. So it's about 70%, and then the rest of them would be other organisms that are part of the Smith family. And so it is in about 10% of these known cases, they were identified as blood isolates, which means they were bloodstream infections. And then in that same period, when observed the number of cases, there were 8 active outbreaks with 25 outbreak associated cases. So the rest of them were isolated individual cases, likely occurring that we either didn't know they're part of a bigger problem, or they truly were just isolated cases. So sometimes we don't know. And in particular, I would say a lot of times you will find that retirement homes or long-term care facilities are not regularly screening for a CPE. Things are changing, and this is changing as well. But if I was to tell you, like 5 years ago, a lot of our sister facilities or our facilities in our catchment areas were not screening for a CPE. So um, within these 8 outbreaks that were identified in that year, 3 of them were NDM outbreaks and 3 were KPC outbreaks, and then there were 2 OXA 48. And then when we started looking into these cases and what exactly we were looking from, where these cases were coming to us that were um, maybe imported or came from somewhere, or are they actually our own cases? So some of these people actually have been in healthcare facilities outside of Canada. And it's interesting that India was leading with 45 cases of 350 cases that were detected in this year. And part of that study was I was actually one of my hospitals was participating, and I was contributing into this data. And I can tell you, I remember looking at some of my patients that were coming recently from their trips and having recent surgeries. And of course, once you, because a lot of facilities will do either criteria screening. So if your patient says, I have been admitted to a healthcare facility, they will swab them for CPE. And the other screening could be, have you been to healthcare facility outside of Canada? So depending on how the screening questionnaires are formulated, and it changes and it varies from one facility to the other. And then you have facilities that do universal screening based on the population they're serving. So they know the hospital is predominantly serving population that is either coming from these endemic areas or frequently travels to endemic areas. So to have a better handle on what is happening within the walls of our hospital, it's we start with universal screening. So don't ask any questions, just screen everyone. And that kind of helps with control and prevention of further spread. But I do remember very clearly entering a lot of my patients that tested positive had visited healthcare facilities outside of Canada. So the next country on the list is Pakistan, and then we have Bangladesh and Egypt and Sri Lanka and USA. I think I mentioned to you guys in a previous class that Israel and Spain have quite high numbers as well. The reason why we are not seeing these cases in our breakdown is not because they're actually doing so much better, especially countries like Greece or Spain. It's just that the when you're looking into Canada as a country of immigrants, you always see certain trends in where people are moving from. So we are not seeing a lot of immigrants coming from these countries like Israel or Greece or Spain. So if there are some that do move in, but this is not predominantly driven by these particular countries. So that's why you see that there is a different representation. When you take a look at the problem globally, you will see that there is countries, as I said, such as Greece, such as Spain, such as Israel, where we do know that these numbers are driven by accessibility of antibiotics in over-counter access. So in Canada, you can't really go out to the pharmacy and easily acquire antibiotic, where in some of these countries you can just walk off the street into first pharmacy and get any antibiotic your little heart desires. Not necessarily that people do know what type of antibiotic you need for treatment, and that's where the problems start arising for us. So when you start looking into other organisms that are causing issues in our healthcare facilities, one of the biggest organism, and you will find as we are going through into antimicrobial stewardship, this is one of the biggest targets. Everyone wants to bring down the numbers of C. diff cases and bring down your C. diff rates. So if you're looking into the previous organisms that we discussed, such as MRSA and VRE and ESBL and CPE, C. diff is actually the first one that comes with a case definition. So you know what is actually defining this infection. So when you look at C. diff as an infection, there is your lab confirmation of the case plus symptoms, or there is, if sometimes it will happen, I had in few instances a case where my patient would have diarrhea and then doesn't have diarrhea and then it goes back, has diarrhea, and every time we test them they test negative, and I have no explanation why is that, but it just sometimes it does happen. And then usually physicians will order colonoscopies or sigmoidoscopies to look for these pseudomembrane changes. And with C. diff in particular, it does have this affinity to attach itself to the walls of the colon, and then it does start extracting water from the body, brings it in, and the toxins that the organism does produce are sloughing off the mucus of the colon, and it does create these pseudomembranous tissues that you can easily visualize on after you're looking into the scope. I really didn't know what to look at until I had someone show me, and it's so easily visualize when you have someone to show you what you're looking at. So if you have an opportunity at your workplace to take a look at some of these pictures and images of the pseudomembranous changes in colon, it's pretty impressive to actually take a look. I don't think the patients think it's as impressive as much as I do, but you know, they're just patients. That was a joke. So the other things that we are also looking could be also the histological and pathological diagnosis. So when we are actually collecting the tissue and looking at that, and of course the megacolon, that's another big thing to look at. Your patient will present with loose, watery stools, and when you're collecting these specimens, when we are talking to the frontline nursing, we are always saying if it's taking a shape of container, collect it. And sometimes they're worried that it has mixed with urine. Of course, you don't want anything that is mixing with the urine, so we have to find a way to collect specimens in a fashion that are valid and viable for testing. So usually it is depending on who is your lab, but you will get usually within the 24 hours a result back. Any questions? I think I heard someone. No, okay. So, oh yeah, so this is important. Sorry, I just flicked to the next slide. But if your patient is on laxative, so this is important when you're calling the case. So, as per definition, when we are looking into C. diff cases, it has to be unexplained diarrhea. So, if your patient has been on laxatives and they're newly introduced laxatives, and you test them, and even if they're testing positive, from the clinical perspective doesn't change anything the way the physician is approaching this particular individual problem. However, for us as practitioners, we are not counting this because this particular case did not meet the definition, because there is an explanation for C. diff, for diarrhea rather. All right. So once you start looking into this case now, that it has definitely met that case definition. So we had diarrhea, no laxatives, and we have a lab confirmed case. Now you're looking at how are we attributing this case? Is this something that is this something that is attributable to us, or is it community acquired or associated to admission to another facility? So to answer your question with regards to IV antibiotics, antibiotic use is actually a proponent and cause for C. diff. So if someone tells you, oh, it's okay, they have a C. diff, that's because they got antibiotics. That is a problem. This is why we want to know whether your patient has been on antibiotics and then tested positive for C. diff. So you want to think about your antimicrobial stewardship and how to manage the use of antibiotics. So yes, some antibiotics will have a side effect as diarrhea, many other medications will, but you should not have diarrhea plus C. diff and then someone tell you don't count this case because they were on antibiotics. That is actually a contributing factor to development of C. diff. So when we are looking at attribution to our case, there is PIDAC gives you a very nice definition, and it speaks about the symptom onset. So were the symptoms present on admission? And this is where the charting is really critical for us. I find often due to lack of charting, the cases get either attributed or not, depending on how a facility functions. But you always want to make sure you have a baseline documented. So educating frontline nursing to document the stools, whether this is a diarrhea or not, is critical, because I find quite often people would document within defined limits, and that within defined limits continues while we are testing our patients for C. diff. So there is some discrepancies between the documentation and the real state of what is truly happening, what's the real picture. So you want to make sure that you do connect with your educators on the unit, and you cover that part, so you know that when you're reviewing chart, you know that information in that chart is reliable, so you can say with certainty that what you're looking at is accurate reflection of the true state of the patient. So you actually can say whether that symptoms have occurred before 72 hours or after 72 hours after admission. So that's how you're attributing the case to your own facility. Also, if the patient is coming to your facility and it is presenting with signs and symptoms, you have to look back if there was a previous admission to your facility. So say it is now June 18th, and today Leonard, who has now MRSA and VRE, he's coming to emerge and he's presenting with diarrhea. And you say, that's okay, we test him, he's positive for C. diff, and that's not where we stop. We have to take a look whether Leonard has been with us in past 4 weeks. So if he has been, say, in our hospital admitted to one of our floors, say June 1st, he was discharged and there was no symptoms, this is still attributed to us. Leonard is going to tell me to stop harassing him. Yes, Bernette? Okay, so when the case is not attributed to us, to your facility, and this is the same definition you're using when you're trying to determine whether a case belongs to a particular unit. So it's the same definition, you're just changing it. So if you have units and your patient is a long-term stay patient, so this is the same definitions you are this is usually a definition you will be following. So when the case is not attributable to us is when the case is the symptoms rather are present on admission, or the symptoms develop under 72 hours within admission, so 72 hours or less from admission. So that is either attributable to community or another facility. But you, again, you have to be careful looking at, was there a previous admission to the hospital or to your long-term care facility, and could this be actually back attributable to you or not? And also looking into the symptoms, and if you have good source of information, looking whether this is a relapse and if the patient has tested positive in last 8 weeks or 2 months. So that's how that distinction goes between what is attributable to your facility and what's not. And then, so also I think just want to highlight something. We spoke about IV antibiotics, or really any antibiotic use, but also your proton pump inhibitors. So your acid reflux drugs are also known to be a contributing factor because they reduce the acidity in the gut, and that changes also for C. diff. So that would be another contributing factor to development of C. diff infection. And we also asked our physicians not to use the in this particular case, Pepto-Bismol to stop the diarrhea while we are assessing the patient. So once we have established and identify whether they are truly having diarrhea and are we going to test them or not, you don't want to over test either. So in some instances, we would say if there is 3 episodes of diarrhea within the 24 hours, that's usually when we test. Or if you start seeing that even if your patient is having 1 or 2 episodes and it's more or less persistent across, there is no forming in between the diarrheas you want to test, you can always consult with a physician. But we are asking not to use Pepto-Bismol while we are investigating the case. So no Pepto-Bismol for Leonard. So now we have Leonard with MRSA, VRE, and C. diff, and no Pepto-Bismol for him. So this is now another definition for you, which is unique in terms of the antibiotic resistant organisms that we are dealing with. So C. diff would be probably the first one that we are seeing today that does actually have set definition, and it varies from the setting, and also varies in the size of a unit that is attributable to. So for the outbreaks definition, we are always looking into, first of all, that we have truly met the case definition. And once you start looking into these cases of your C. diff, whether it is focus on one unit, or it could be across the facility. So sometimes if you're seeing increased number across the facility, you want to investigate, maybe there is a problem in your endoscopy department, or maybe there is some commonality for these patients, that they're maybe having a same procedure, or visiting a same area in the hospital for either diagnostics, that there could be picking this up. That's just something to think about. It's not always thinking, oh, this is a random case on this unit and random case on that unit, and there is no visible or easily identified link. So when you start looking into cases that are attributable to your units, when you look at the size of the unit, the definition spells out for the unit that has 20 or more beds, 3 new cases of healthcare associated C. diff on your unit within the 7-day period. So 7 days, 3 new cases, or 5 new cases within a 4-week period. So if you have 5 cases in a month, or 3 cases in a week, that is meeting a definition of an outbreak. For units that are smaller, and I had smaller units, I had smaller hospital than 20 beds, that's been becomes really challenging to calculate the rates and actually determine whether there is a problem, and are we having an issue with this particular unit or not, because it's hard to tell. So usually we consult with public health, and they are the ones who bring in the epidemiologist and the medical officer of health to help us figure out if there is a problem and what would be the next steps. But generally speaking, for the units that are having less than 20 beds, you're looking into 2 new cases that are identified on your unit within the 7-day period, or 4 cases within the month. So that's how the calculation goes. So you have to be sure, when you're going back to your case definition, where are you attributing this new case. So if when was the onset of symptoms, that's where your attribution goes. So if the symptom onset was June 15th, that's when you're counting it, and you're looking in retrospect until May 15th. So that's when you're looking into the numbers that you're counting. And anyone who's developed symptoms within that period, you're including these people into this outbreak, or your line list, if you wish. So it is contact precautions as well. Sorry, I didn't really include that here, but it's contact precautions, and it's always sporicidal cleaning. So you want to either use bleach or accelerated hydrogen peroxide. There is some new methodologies that and tools that are available to us to use. I don't know how many of you had an opportunity to see the UV light in action. That said, it is additional layer for disinfection. So you will use it, you will clean the room in a regular way, clean, disinfect, use your sporicidal, and then roll in your UV light to do another layer of disinfection. I usually find it that facilities that were facing a number of challenges with C. diff do invest in such equipment. It's one of those things, it's nice to have. If I was to asked which way to invest that money, I'd always want to have more hands that clean the rooms using proper disinfectants than some of these additional pieces of equipment, which, as I said, it is, you still have to clean, you still have to disinfect, and now this is additional layer. It's a nice thing to have, and it's kind of fancy to see them around the facility. Sometimes people like to enter some sort of competition, naming them and dressing them up and decorating them as they're going through the units. They're kind of quite cute. Some of them look kind of like a, is it I don't know, is it 3PO? I think it's 3PO. Kind of look like a little garbage can on little wheels and has the UV light. Others kind of look like, I think of them about like aspergillus, kind of long legs and long arms that spread around the room. And then there is ones that kind of look like massive heaters, and they kind of turn and spin around. So I don't know if you had a chance to see them, but those are some of the types that are present in the healthcare facilities to do that UV disinfection. One good thing about them is that they're really good removing the smell of urine. So what is different between your C. diff outbreak and ARO outbreaks is the way we are calling these outbreaks. So when you start looking into cases of MRSA or VRE or CPE, as I said, I don't really see anyone calling an outbreak on ESBL. Sometimes we do see increase numbers, but I've never called an ESBL outbreak in my career. We are looking actually at the calculation. So you're looking if there is an increase in rate. So you want to go back to your line list that you're keeping all your numbers from previous years, and you can put all your numbers together and look at whether there is a true jump there, or is this something that is not really to be of any concern. When you start investigating any of these new cases or suspect clusters or suspect outbreaks, what we do is start surveillance, start screening. So usually it is either a point prevalence or period prevalence, where we are screening our patients for extended period of time. Really, there is no particular prescriptive rhythm and how you're doing this. You just want to make sure that is happening. When you're doing your point prevalence, you're capturing everybody on your unit. So however many patients you have on your unit are being screened at the same time, and then you're sending these specimens together to the lab for processing. And generally speaking, I've been doing anything between 3 days and 5 days point prevalences in the past. Usually that's been decided with your infectious diseases physician and your team based on the findings that how did you end up in this situation. So if you're seeing that you're having high numbers and there is a possibility that the transmission is still happening, you want to capture in between the shorter period, I would say. So sometimes we would say let's do it every 5 days, and then something happens, like patient maybe goes for procedure, and when they come back we screen them again and we pick up on that. So that's when we decide to shorten the period between the prevalences. So that's how you start looking at that. And then within your calling your outbreaks, we will have entire chapter on it, but usually you start with identifying that there is a cluster and putting measures in place to prevent that from growing into an outbreak. Clusters are not reportable to public health. Outbreaks are reportable to public health. So there is entire list of organisms that we have to report to public health by law. It is reported under the Health Protection Promotion Act, and then your outbreaks are a separate reporting that doesn't go to the same bucket, so to speak. When you start screening for MRSA, usually MRSA and VRE are done on the same set of swabs, unless you're only seeking and searching for MRSA. And then usually those are your dual swabs. You're collecting your nasal and rectal swab. And in cases where your patients have stomas or any types of wound, you are collecting that as well, and clearly identifying that on the labels that this is a different type of specimen, so the lab knows what they're dealing with. When you're collecting your VRE specimen, it's only rectal swab, and then same thing for ESBL and CPE. With CPE, you also may be looking into some clinical specimens, just like a ESBL, but predominantly it's for the colonization purposes. When we are looking into colonizations, it's nasal rectal swab for MRSA, and for the rest of them is a rectal swab. All right, so next organism, next bug we are covering is influenza. Is everyone with me and still awake? Am I losing people as we are going through? Sharon, I didn't tell any stories about the foodborne illnesses. I'm sure you can have some snacks.
You're awake.
That's good. I'm glad.
I'm having
So,
some popcorn.
yeah, I hear something crunching in the background. All right, that's good. So I'm glad everyone is here. No one is having any questions. So I don't know if I'm answering all your questions ahead of time, or maybe we will discuss something later. Good. So with flu, we touched on flu last week from the micro perspective. So we are going to talk about flu in terms of healthcare associated infections and management of cases within your facilities this time. So as you know, there are three different types. Predominantly circulating types of influenza are A and B. We covered that last week. And it is, when we are talking about healthcare associated cases, it is a human reservoir. I don't think we are getting any reports that a person got in a healthcare facility flu from a bird or a pig. There is a first time for everything. I'm looking forward to years in IPAC, but predominantly it's human to human transmission. And what's really, really important when we start investigating these cases within our own facilities is to know the incubation period. So you will notice that for the AROs, there is no set incubation period. We actually don't know the timelines in terms of how long does it take from exposure to become fully colonized and actually carry so much organism that we can pick that up on a swab. That's nowhere mentioned in any of the documents that speak about these organisms, where we know for influenza infections incubation period is 1 to 4 days. But what we also need to know is that people may be infectious 24 hours prior to symptom onset. So you may have somebody come to our facility, or some of our staff today, they're just fine and perfect, walking around and working with our patients or residents, and tomorrow they call in sick, and that's something to be concerned about, because they could have exposed their other colleagues or our patients. And the same thing with our patients that are within our facility, and suddenly they become sick while they were sharing a ward or a semi room with other patients. So in those cases, what you want to do is you immediately start isolation of the known cases and also exposures. And I did not mention to you guys for MRSA or VRE and CPE, the same thing goes when we have exposures. We are isolating and screening the roommates of these known cases. So if I have now just spun you out of the topic, we can revisit that. But I just wanted to make sure that when we know of known positive cases, we are always screening their roommates and exposures. So with influenza, as I said, the risk sits within that incubation period when we know a person could be shedding without actually being symptomatic. In most cases, people will be most symptomatic and shedding the highest number of viruses, so to speak, would be the 3 days in the illness, and then usually people recover within 7 days. So this 7 day period is important for you when you're managing your outbreaks to know what are we waiting for. So we are waiting for that last person to fully recover, and then you're counting from there, looking, is there a new case? So you're always looking at the new cases and the way the transmission occurs. So it is a droplet transmission, so it is transmitted through large droplets. What is really important about influenza, and I find that with talks about COVID and aerosolization, it is important to know that influenza too can be aerosolized through the same AGMP methods. We spoke about it in our discussion, so I've seen some really good feedback there and a lot of good thoughts. So influenza as well can be actually aerosolized and become airborne if we introduce some of these, either high flow oxygen or intubation and so on and so forth. But as a regular transmission, it is droplet contact. And if we are looking, so we were talking about the RN numbers as well. So if you take a look, for example, to compare influenza with COVID, so in the past, I don't know how many of you had an opportunity and were blessed with facilities that have no private room. So we were forced to put our influenza patients together, or sometimes one of them develops symptoms. Um, while the rest of them are in the room. So we would find that it's not as highly transmissible as your COVID. So with influenza, it wasn't always a case that if you share a room with influenza patient, you're gonna get 100% influenza. Where with COVID is a little bit different story. If you've been in that space, chances are you're getting COVID from that exposure. So for droplet contact precautions, same thing. We are putting patients into private room if possible, every time when it's possible. With in some extenuating circumstances, you may get away with pulling a curtain. Becomes a challenge managing isolations behind the curtain space, because we are coming in and going out and we want to observe our patients in the room, so that becomes a bit of a challenge. As for us, what are we wearing? We are wearing gowns, gloves, mask, and eye protection. So it could be a mask with already installed visor, or it could be just a mask with a separate either visor or goggles. So usually what you want to do is move your positive patient into a private room. What you don't want to do is introduce another patient into this space where you now have an exposed patient. So general rule is move a positive out, and if you can accommodate your other patient in a private room, if not, you block the bed. And you don't want to bring a new fresh non-exposed patient into exposure room and now just continue with further transmission. Does that help, Lisa? Are you asking, would I leave a negative patient in a room with a positive patient, or would I leave a negative patient in a room that's potentially contaminated? So regardless of if the second is the question, you want to make sure the room is cleaned. So once you remove the source, the risk is significantly reduced. If the surfaces are contaminated, it's really not something that's jumping off like other patient's bed or a bedside surface. So you want to make sure that the room is terminally cleaned. So generally speaking, every time you move your positive patients out, you want to ensure that whoever is in that room remaining, it's in a clean space. You could. It's just that becomes like, if you're looking into a long term risks and what could potentially happen. So because we don't have as many private rooms as a rule of thumb. So you want to give the private rooms and block as least as possible number of beds. So if you start blocking these beds, then you stop the flow of the facility, and that becomes another challenge for your facility.
Yeah, if we have a shared room, we would move the positive also,
Mhm.
and then clean the room with the negative person in there.
That's right. So with and that's usually what happens, and in hope that this is your only one positive patient. So, and you don't want to leave them in that room, block that room, and especially with something like COVID. I mean, COVID is really not a good example because it's so crooked in so many ways. You look at it, but if you're looking into diseases that may have an extended recovery time, so it takes longer. So if you're blocking that room for that positive patient, that means less patients are taken care in your facility. COVID has been really tossing everything out of the window what we are talking from day one, from the infection control perspective, generally speaking. So this is not a good example to use, but I think if you're talking about your MRSAs, you always want to move your positive patient out and clean the room, and then that exposure may actually not have may not convert. So while your MRSA positive patient is going to be positive for pretty much forever, really. So they're not going to be accommodated in a private room anytime soon. But that exposure may actually turn out not to be positive, so you can admit into that room again, if that makes sense. It's absolutely not feasible. You're right, but in facilities that are old, extremely old, where you have a limited number of private rooms and even semi rooms, and all you're dealing with is quads and sometimes even like 6 bedrooms and what have you. It's a ward, really. It becomes challenging managing what we are dealing with, and I think, and I do hope that moving forward, we will be looking into building our facilities in a different fashion from what we have been doing in the past. I remember sitting in a meeting where we were discussing waiting rooms for the patients, where we were demanding separation in the waiting room to allow for that 2 meter separation for, of course, we didn't know for COVID back then when we were thinking about this, we were thinking about influenza season, and the architects were just not having a good time with us and absolutely dissing our comments because it's ridiculous amount of space that they would need to place the chairs. And look at this now, wherever you go into any waiting room, there is a 2 meter separation in a circle around the chair in the waiting room, allowing for that two meter separation between individuals. Things do change. So you're right. Sometimes we do keep our patients in a room and the separation is achieved by curtain. I would say we know that with COVID that is not recommended, where if you were dealing with good old pneumonias or influenza, that was still acceptable. Ideally, you want to move that patient out. um, you can provide to the patient a mask and whatnot, because no matter what happens, um, the move doesn't happen immediately the moment that result comes through. So there is always that gap period that we have to manage our patients in. Even in the ideal world where we do have space, you still want to make sure they're safe. So in that instance, while we are waiting for the move to happen, you still want to pull up the curtain, put a mask on each of the patients, the positive and exposure, to reduce that risk of further exposure. Sometimes I find nurses like to roll the exposed patients out in corridor, which I have a problem with from the risk perspective as well, because they think they're reducing the risk of exposure to that patient B. However, the patient B could also, by this point, could be actually incubating and shedding without us knowing. So the least movement we can do until we can do that in a safe fashion, making sure no one is at risk. Right. So let's go back to our influenza, the good old influenza that we all forgot last year about. So when you're looking into your case definitions, they're set by the government, by the ministry. So you're looking at, you have to have a lab confirmed case. So it is your MP swab that is collected, and now it's confirmed by the lab. And it could, we do accept also throat swabs, although they're not producing the highest yield, such as the nasopharyngeal swabs. The alternative to it is also the clinical diagnosis. So you would have to have a physician set a diagnosis without that confirmed lab case. That doesn't really happen so often. I can't really say that there were many cases where this would be happening. Usually, when we are managing an outbreak and there is a limited number of swabs that are being processed by the lab under that outbreak number, then we just go with, this is the symptomatology uh, based on what we are dealing with. If there is a unit that is 25 beds and you had flu that was going through, and at this point you have 14 or 15 positive patients, a couple of staff, it is a safe assumption, if your patient is presenting with flu-like symptoms, that they will have flu as well. But as I said, it doesn't really happen too often that we will get a diagnosis without a laboratory confirmation. And then you can look also at the epilinks. That's what I already mentioned. So it's usually a geographical area that you have identified as high risk, or if you know that we already spoke about these direct roommates and direct exposures, or where you had a confirmed sick staff that has taken care of this patient. So poor Leonard, for example, now Vernet is taking care of him. Vernet came in with flu, and not only does he have MRSA, VRE, and C. diff, now he got flu. And we have confirmed from occupational health that one of our staff has been testing positive. This is a good epi-link to think about, that this could be also if he is presenting with with the symptoms. And then of course the detection of influenza, the RNA testing.
Is
By the
Leonard
time
going to die?
by the time we are done with the class, Leonard is
He's
just
gonna be
gonna.
dead.
It's okay. He's not so involved. We are picking on him. Don't tell him.
We're burying you tonight, Leonard.
It's just a sign of
Oh, I
our
better
love.
stop it. I'm stopping. I'm stopping. I'm sorry.
So when we declare any of these outbreaks, you will find that first of all, we always use the signage on the doors. So you will, for influenza, it's droplet contact. I put up the sign from Public Health Ontario. They're accessible and available to anyone to download. In the past, they used to have these super cool signs that were wipeable, and they were just handing them out for no charge. But now it's up to us what to do with the signs. We have to be careful when if you are using them. Some hospitals and long-term care facilities decide to print fresh signs just on paper, no laminate, and they just discard them after they're done. Others will choose to laminate, and you can wipe them down when they're done. realistically speaking, they're really, no one's touching them. No one should be touching them. So they're not really like a doorknob or like a bedside table. They shouldn't be contaminated in as much as the other surfaces, but you should be able to manage that as well. And then other things to also is important is that communication that is posted. So usually we post that if we are in an outbreak, um, we end up on the list of the outbreak facilities that is issued by your local um, healthcare health unit rather, and then also we as a facility usually post that on the landing page that our facility is experiencing outbreak on such and such unit. And then also you want to communicate with the families of these patients so they know what is going on, what are the risks, when are we swabbing them, and so when they talk to their loved ones, they know what's going on. Especially if you're going through outbreaks that do require frequent swabbing. A lot of people get very uncomfortable, and after you're done with 55 rounds of swabbing, everyone is sick and tired getting stuff shoved up their cavities. So the help from the families is significant to us through this period. When we are calling an outbreak of influenza, again, it's very prescriptive. It's given, it's downloaded from the ministry. Usually you can find these definitions also on your local public health unit's website, and it speaks about 2 cases of acute respiratory infection. And what is really interesting about influenza outbreaks, you don't necessarily need to have both confirmed, lab confirmed cases. So that's a little bit unique in approach. So you may end up with somebody who may have a rhinovirus or one of the other respiratory viruses that are circulating through the season, and it's called an outbreak. It's called a respiratory outbreak. What is important is that 48-hour period between the 2 cases, and that they are on the same unit, or that there was some common epi-link. Or alternatively, you're looking into 3 cases that are laboratory confirmed, that are also occurring within the 48 hours and with any links as well. So that's kind of how your outbreaks is declared, and it's always declared with your public health unit, and the measures that you agree on are always discussed in your outbreak team meetings. I'm sure with COVID many of you have witnessed these meetings, but if you like me to talk about it, I definitely can speak to that if it's something that you guys are interested. Yes, absolutely. You're looking at both staff and patients. And when we speak about staff, I just want to highlight that we often forget about some of these staff members that are not your frontline nursing, for example. So we would forget about food premises, or sorry, food services or housekeeping staff that does work on the units. And I find quite often what happen if you have assigned housekeeping staff. So for example, let's bring Mary back. So Mary has been taking care of this unit for 5 years, and today Mary had a doctor's appointment and she went to for her meeting or appointment, and someone else covered for her. And that's when we find that we have these gaps and we miss to to connect the dots. If they would go to occupational health and they do report, but normally we would say they're either floating staff and they don't often they often get missed and not properly linked back to the unit. So it's important that we are aware of these possibilities and ensure we close the gaps and make sure we are able to track what's happening. Usually your occupational health will ask them, where did you work? Did you go here? Did you go there? Did you wear PPE? And so on and so forth. So the next organism that I have encountered in the past, I know a lot of my colleagues have been dealing with this, and I'm sure some of you have seen it too and will see it, is norovirus. It is oral fecal contaminants. So, sorry, Sharon. Usually, it is people shed it through feces, but also in in cases where it's emetic, so we have patients who will be vomiting. Usually you'll find this in younger population. Younger children tend to vomit more versus adults. They do vomit as well, but not as much as young kids. And what is interesting about your norovirus is that you start shedding before you're symptomatic. So when you're investigating a case of norovirus, so if today is 18th and you have a patient that's been symptomatic today, and I'm sure by the end of the day you will have more than one, you want to take a look back for that incubation period to see was there any staff that reported sick, that they had diarrhea, and they haven't been coming to work since. So you want to include them into that surveillance as well. With norovirus, it's also important to know that some populations will be asymptomatic shedders for extended period of time. Cancer patients, chemo patients can shed actually up to 6 months after the disease. It is oral fecal contaminant, I already said that, and it is a droplet contact precautions. So when you look into documents that are speaking about precautions and mode of transmission, most of the documents are explicitly stating contact precautions. But because we do know that in case of assisting a patient with emesis and you're so close to them, and that at vomiting matter will contain virus, you want to wear a mask and a shield. So that could be a part of your routine assessment and risk assessment. But to prevent and take away that risk, we usually, when we are dealing with norovirus, we say droplet contact, put a mask on with a visor, gowns and gloves. And also cleaning and stool management is critical in this case as well. So when you start looking into your cleaning practices, you want to bring more manpower on the unit, and it's usually what we refer to as cycle cleaning. So it does not stop. You're constantly cleaning the unit. They're cleaning high touch surfaces, things like rails and doorknobs, and use of the washrooms. Every time you can designate a washroom to your noropositive patient, you do so. Given the spread and the attack rate of this particular disease, it's challenge. So you end up often having roommates over roommate, and just because of that lag from shedding to actually expressing symptoms, we find that norovirus actually travels quite fast and has a significant impact on the unit. For you as a practitioner, it's important to highlight stool management. And how do we manage stools? So some facilities are lucky to have macerators, others are not having macerators. There's different thought and different school of thought around use of macerators for environmental impact and so on and so forth. But when it comes to stool management and managing some of these outbreaks, macerators are God sent to us. Alter- Really good alternative to it is actually those I'm going to use brand names, but those are absorbent bags. So you will come across either Zorby or Hygie. I'm not familiar if there is any other different brand names, but what they do use, they're using recycled diapers. And when I say recycled, not used, just the diapers that have not passed the quality control, and they're using the gel from the diapers and creating this new product. So what happens if you have either the bag that you provide to your patient that are vomiting, or if you're giving them these liners and bags to put on the bedpans, this solidifies this or creates this gelatinous mass of these liquid body fluids, and it reduces the spread and the risk of disturbing and aerosolizing this. When I say aerosolizing, I don't think becoming airborne. It's just it does lift off the surfaces. It does lift of the bedpans, especially if you're washing them. So you want the least amount of manipulating of any of these bodily fluids or excretions to make sure that you're not spreading any further. Once you're done with that, you want to close it tightly, remove your PPE, and wash your hands with soap and water. And with regards to hand hygiene, that's probably one of the cases where we would say to definitely wash your hands with soap and water is whenever you're managing stool. Because again, as I mentioned before, stool is so fatty, and with some of these organisms like C. diff, you can't kill C. diff with alcohol-based hand rub. You actually have to wash it off. So when we, so I think Sharon is in for a treat. I'm just gonna say this. So it is a direct contact to either feces or vomit, or indirect contact through contaminated surfaces, and it is a fecal oral contaminant. We also have witnessed situations where the food was contaminated by the people handling it, whether it's due to poor personal hygiene or missing hand hygiene, and contaminating foods and drinks, and then entire shift is taken out because they were eating some of their common food. I think COVID has removed a lot of that, but something to that we can reflect and look into past how we used to hang out together and eat things together. All right. So next one I want to touch base, and I think this is um, everybody is quite comfortable with this one, but it's impossible to not talk about this particular um, virus, given that we are dealing with it in this past almost 2 years. Um, the way we set up definitions, you're starting off with a probable case, and it's set by the Ministry of Health. That's what they're looking at. So you're looking at people who have had any type of known exposures, whether they traveled to affected area. Yes, so it's either Zorby or Hygie bags. And actually, they're both Canadian products, so it's Hygie actually has a really cool story behind. Not again, I have nothing out of it. I'm just sharing what I know. So it is actually from the owner and the developer of the bang itself. He is quadriplegic, and he was in the hospital and experiencing some of the consequences of vomiting and diarrhea, and he found it quite interesting how stools was managed, and he started investigating how he can help in stool management. So he actually came up with the recycling of diapers. So yeah, another little trivia that no one really needed to know. But anyway, let me just go on a tangent here. So back to our probable case of COVID-19. So you have to have known exposure, either traveling into the area that is endemic or known that they are dealing with outbreaks, which now is pretty much everywhere around the world, or have a known high risk exposure with another person of that is confirmed case, or you have been a part of either cluster or outbreak. Usually we are looking at these at either healthcare facilities from either our patients or the staff. And then you're also looking into your lab confirmed cases, or so your PCR testing or the rapid testing. So when you start looking into your rapid testing, you have to know whether that's been approved test or has it not been approved. In most of our facilities, I can't imagine we are bringing something that is not approved, but I'm sure there's going to be something to learn about that as well. And then also you're looking into the symptoms and whether these symptoms are in line with COVID-19, right? So if you have a patient that is presenting with symptoms and the lab, which is your the PCR test, is inconclusive. So sometimes that's when we talk about these CT values, right? So they will say inconclusive, and when you ask them to expand on the result, they will tell you that the CT values are high. And what that means, it could be that either is it's a new infection and you're catching it right at the onset, or it could be that this is an old infection, so it's person recovering and they still may have symptoms. So most likely in case where you're seeing somebody presenting with symptoms and high CT values, it is likely that you're catching them at the early stages of development of the disease. And then your let me just finish this and then I'll come back to your crystals there. So with if your patient is asymptomatic, but they had a high risk exposure, so they have no symptoms, but you know that they had a contact with a known confirmed case, or they have been exposed to a cluster, just because we do know that these people will eventually convert. So those are when you're deeming them as probable cases. And then for your confirmed cases, of course, that's very straightforward, I think, anyway. So you have to have your confirmed PCR test, or as I said, these some of these tests that are acceptable, also the rapid test. But your PCR test is a gold standard. So that's what you always want. Even when you're running your rapid test for surveillance purposes, you always follow up with the PCR test for confirmatory purposes. And also your rapid test cannot show you CT values or further testing for the variant. So you want that PCR for further identification if you're dealing with a variant, or if you're looking into these CT values, which usually is how we investigate these cases. And then also, again, if you're looking into your seroconversion, so that would be the blood that you would be collecting, and you're looking at the um, whether there is a seroconversion when you're assessing the blood specimen. So that's a different test altogether from either PCR or these rapid tests. So that's a whole different test. That's when you're looking into your conversions and you're looking into the genes, IgG and antibodies and all that. So the crystals are packaged in dissolvable plastic. So the crystals are actually coming in just like you are looking into a diaper or a feminine pad. So they're kind of in that a soft fabric. I think it's more of a cotton, really. I'm not sure what it is, but it's part of a liner. So it's not loose crystals. It's actually gelatinous mass. And then when you add a liquid to it, it solidifies the liquid. All right. So then when we start talking about COVID outbreaks, I know some of you mentioned you were so lucky you didn't have any outbreaks. But unfortunately, it's been so prevalent in our community, in our healthcare facilities, that you just could not go by without hearing in the news. And I know that I'm going to tell you something that you all heard, but it's just because we are going through this topic and I want to make sure I touch that as well. So when you're declaring an outbreak in a hospital is different definition from what used to be also in a long-term care facility that's been recently updated as well. But for outbreak declaration in a hospital setting, in acute care setting, they're looking at two or more confirmed lab confirmed cases that are epi-linked, geographically linked, and then you're looking at that 14-day period because that is the longest incubation period and you're looking whether something is actually happening. Although through the COVID outbreak, we have noticed that the incubation period, it's quite frequently identified incubation period about 8 to 9 days, and most commonly your patients will convert if exposed by day 11. We had some cases that were on day 14, but by by and large it is by day 11 you'll see most of your patients converting if they've been exposed. And then when you start looking into the definition for the either long-term care facilities or retirement homes, they're looking as one lab confirmed case in a resident. I know that there is some discussion with regards to immunization and how are we gonna be managing these cases. So it doesn't matter whether the case is staff or patient or resident. It is once we have these cases, we are declaring an outbreak. And because of the length of the disease itself, these outbreaks are quite cumbersome and lengthy and takes forever to come out of them. If you think about outbreaks such as influenza, where we are looking to declare an outbreak, 2 incubation periods plus 2 days, this is a completely different extent when you start looking into month to declare an outbreak after you declare it, once you put it in place. So the same thing, once you start looking into a patient, you want to make sure you are placing them in right accommodations. We already discussed to great length that we simply don't have the means to place everyone in a private room. So what then we resort to is cohorting. So that's Ministry of Health. So when you start looking into cohorting, you have to be also careful who are you cohorting with, who are the people you're putting together. So before the variants, we were really quick to say you can put a known positive with another known positive. We were also putting known positives with recovered, and also recovered were really like your wild card. They could go with anyone. And then once the variants entered the scene, because we did know and do know that there is a possibility of getting co-infections or after recovery from the wild strain, which is your main circulating strain, there was a possibility of acquiring other strains. So the school of thought around cohorting has changed as well, and then we had to revisit practices that we were following. That said, I have not seen in my practice anyone um, become either reinfected or get another strain in quick recent time of from the previous infection. I haven't seen anything like that. It doesn't mean that's not possible. I know that reading the papers, just like you guys are reading too, you're finding that that's a possibility. But in my work, I haven't seen that. So what do we do? What have we done to manage so far? Oh, that is so cool. Yeah. Negative pressure is critical in cases that you're dealing with aerosolizing procedures, and whenever you're dealing with vented patients, that you're putting them through the ventilation process. But once they're vented, you're fine. The problem arises that you have a lot of patients that are on high flow oxygen, and they do need to be on negative pressure rooms. A lot of facilities cannot share what what we just read here. There is no facilities that have 40 private rooms or that are lucky to have 40 negative pressure rooms. So most facilities will end up with again, do the risk stratification and looking at what is your best bet and who is your highest risk, and placing those patients into negative pressure rooms. So usually we would say anyone who is on high flow and of course has been recently positive, we are keeping in a negative pressure room. For other patients that were either on nasal prong or vented, we were putting them in private rooms. And even if there is some the procedures that were happening at the time that were just intermittent procedures that were aerosolizing, you can't keep moving these patients either. Some of them are so unstable, so you would just close the door and staff would be wearing N95s, and then you're waiting for that clearing period, depending on um, depending on really on mechanical makeup of your room. So you need to know what is the air exchange rates in the rooms. So for example, for your negative pressure rooms, ideally you want 15 air exchanges. But for your regular patient rooms, depending on when they're built and what is um, the HVAC system behind that, you can end up with 6 to 12 exchanges. And so you have to calculate how long it takes to have as many air exchanges to clear the room. So that's how that works. So what have we done to manage and how do we manage COVID? As I said, accommodation, hand hygiene, of course, critical. And I can't stress enough importance of cleaning one's hands before removing PPE. And I know I discussed with some of you those challenges with the frontline staff because everyone's just fatigued from removing and putting things on and off. So we have to drill that back in and make sure we stay on top of it because hand hygiene is critical. If you're touching your face, which is the portal of entry, you're putting yourself at risk. Screening is another thing that we have done. So either there is active screening or passive screening. Usually it is done through at the entrances to the facilities. Depending on the facility, some have opted out to have a combination, but the Ministry of Labor and Ministry of Health is actually asking and has been asking for a while for active screening. So for the staff, you have often larger facilities have been using apps where you go through the questionnaires, but you still have to go through seeing a person who kind of lays their eyes on you really to see if you are coming through with fever and sniffles. How people can avoid it, and I know that it became really a challenge with the allergy seasons as things started blooming. A lot of people were having sniffles and quite concerned how they're going to pass through the screening. But what's important is to be honest and straightforward and actually say, because if things do not work out the way you were hoping, the consequences are tragic for the patients and residents. So education is a big piece, and through the education we cover, generally speaking, your frontline staff, but also the patient population. And I spoken to some of you guys about the education around the immunization. And in past we've spoken about the adult education, and what's really interesting about COVID is how much it has brought up these for lack of better term, trolls that are sharing wrong information or bad information and creating a lot of problems for vaccinations and creating a lot of resistance in general population by questioning and not necessarily providing all the truthful and valid information. Yeah, so I find a lot of facilities, and especially in ICU, the nurses actually smartened up to prevent the frequent entering into the rooms. They were bringing the pumps out of the room, so they would connect the pumps with extended lines that in itself became a problem because we started seeing increase in bloodstream infections because these lines were hanging on the floor, and of course people are walking over them and floors are dirty. So those were some of the challenges that we were facing. But once we actually started using these sleeves for, I'm going to try to explain it. I really don't know what it is in proper terminology, but we use these sleeves to cover lights in operating rooms. So anything that has these long arms, there are plastic sleeves, nothing different than any plastic bag, but they're long. And we started using these to cover the lines, and that actually has stopped the bloodstream infections in these cases. So HEPA filters are not creating a negative pressure. So HEPA filters are scrubbers, and there is some negative pressure mobile units, but HEPA filters as alone are not creating the negative pressure room. They're just cleaning or scrubbing the air that is in the room. So I think what we need to look in future when we are building the facilities is actually probably looking into creating all our rooms to be negative pressure room, with exception of few that must be positively pressurized. So when you're looking into makeup of facility, we will get into that towards the end of the course. But there is like your surgical sites and surgical the theaters and operating rooms, you definitely want these to be positively pressurized. But most of the rooms, you can get away for them all to be negatively pressurized. And to retrofit an existing facility is really expensive and a lot of work. But when you start thinking about building facilities in the future, I think this is probably where we're going to go with have preset negative pressure rooms. So in the past, CSA standards, who is dictating the rules around building the healthcare facilities, was actually allowing for for the rooms that could be changing the pressure by the push of the button, but it became a challenge as well, and they're stepped away from these recommendations, and they're advising not to install the switches that actually change the pressure in the room from positive to negative and vice versa. So when we look into our clusters or outbreaks and transmission in relation to any of the organisms that we were talking about, it is important to first be able to identify whether there is a case. So, is there a healthcare associated incident? And then what do we do to prevent a further spread? So, through your understanding of what is a chain of transmission, understanding that there is an organism, that there is a host, and that there is portals of entry and portals of exit, and what kind of measures are we putting in place to prevent these organisms that we already have on the unit. So with regards to clusters and outbreaks, you don't always start with a healthcare associated case. You could start with a case that came from the community, and now due to failures in the breaking the chain, so we missed some of the opportunities to act upon, we actually do allow and perpetuate the transmission. So then you start looking into your clusters, and then you start looking from the clusters into outbreaks. Sometimes you completely bypass the cluster because the number of cases is already meeting your case definition for an outbreak. In the past, you will know for long-term care facilities, there was one case for COVID, and you were already in an outbreak, no questions asked. Where um, if you're looking into influenzas or C. diff, you actually have some space to work there. So what is the definition of a transmission is one new healthcare associated case with approved EpiLink. So you had one case and now you have a new case on your unit. That's a transmission. When you start looking into clusters, so that may vary from an organism to organism, but it always speaks about this continuous transmission. So you have to have more than one patient on the same unit. So you have to have two cases at least, but it could be more that are closely related and they have a time that are occurring in the same time. So within that incubation period or the duration of the illness, with the arrows is a little bit different again. And then you have to have that EpiLink. You have to have a common source or a common environment that they're living in. And then when it comes to outbreaks, back to definitions, your C. diff and influenza and norovirus and COVID come with very prescriptive definitions. They're given by the ministry and downloaded to us through the public health units. But when you're talking about AROs, we already discussed this, I mentioned it a few times, you have to establish and calculate your rates to determine whether there is, whether you're actually in an outbreak or not. So once you have got your information, now you have to figure out, are you actually in an outbreak or not? So first you have to determine whether there is a case. So you have to meet that case definition, and now you have to meet the case definition for an outbreak. So whenever we are dealing with an outbreak and suspecting, you have to confirm it. You have to call a team meeting and involve a number of different partners to help you navigate through this. Usually you will work very closely with your lab, you will work with the unit and unit manager and your nursing staff on that unit. You want to always step back and look at whether is what you're investigating, whether there's any changes in the definition. So I know every one of us has been keeping up with the definition of COVID and the measures and recommendations. You blink and they change it. Luckily, it doesn't happen with the other organisms as such. This is just because it is so new and it had such a widespread and huge impact. So it was always a fine act of balancing the risks and outcomes and finding the best way to manage these events that we were facing. Um, you want to make sure you are reviewing your literature. You will find in some cases your local health unit will have tighter rules around certain management, and no matter what, you always want to follow what are the tighter rules. Generally speaking, if you are looking into any of the legislations or any of the guidance documents, the higher the government, the rules are a little bit looser, and as you're coming closer to and narrower to particular health units, the rules may be a little bit tighter and very prescriptive. So you want to make sure that you have identified your cases and you are following your case definitions, excuse me. And then you're developing a methodology for case finding. So how are you going to look for these cases? Are we looking for a symptom presentation? Are you swabbing patients, say, for MRSA? And when you get the new cases of whether you have to still look for each one of them, whether they're meeting the case definition. Because you could have somebody on your unit and you're testing them now and they're positive. However, if they're if they're not fitting the case definition, they're not part of your necessarily part of your outbreak. Of course, they're on the unit. You can't really move them away, but you're not counting them as healthcare associated cases. So to help you manage all of this, I always have blank line lists ready for me to go, and just update that, and I just kind of go through them as needed. um, I always put in my line list whatever is the case definition and whatever is an outbreak definition. From your local health unit, you will get an outbreak number. I put that in. I put what type of outbreak is in a heading, and then I also include the time when we have declared the outbreak, initially started the outbreak, and then also what is potentially the earliest time to declare an outbreak over. So when people ask me questions, I have that at fingertips. It's also interesting if you're running more than one outbreak, so it's easy to confuse these dates and timelines. So it's good to have it at on easy to easily accessible. So when you're dealing with your outbreak, always consider um, your environmental sampling. In particular, I'm thinking more about cases like CPE or VRE, not so much when we are dealing with COVID or influenza, but if you're dealing with a group A strep, definitely consider collecting some of the environmental specimens, because that's likely where your contamination is also happening. You always want to make sure that you follow up with the findings. So always, if you have to go back and, as I said, tighten that case definition, usually comes from your public health, but it could be something if you are noticing that you are, say, for example, dealing with population that may not be presenting with fever due to their either clinical presentation or age. So this is something you may want to bring up and say, let's not wait for that person to actually present with temperature of 38 degrees, whatever is that we have defined as a fever. However, let's look at lower temperatures in these particular instances, and continue looking while you're in an outbreak. But also, once you declare the outbreak over, don't stop looking, because there is always a potential you will jump right back where we were a couple of days back. So keep that surveillance going for some time until you're secure in your measures. And then we tend to keep a lot of these recommendations in place for some time after the outbreak is declared over, to make sure that we are not actually um, letting everything go and letting control of the situation. So we know which for sure that once we declare it over, it's going to stay that way. And also, it's good idea to keep these measures in place to encourage staff to follow these practices, because you know that once we are in an outbreak, we tighten all the rules around the cleaning, the isolation, the hand hygiene, but it's good to keep that going to encourage better practices on the unit. So again, I want to just highlight what is your outbreak definition. It is an increase in incidence of diseases that are beyond what is expected for your unit. So you may see normally certain numbers, and that's just your norm, that's your baseline. But once you see an increase, this is something to be concerned and start investigating, and at least have a conversation with your team and your management about your observations. What you want to make sure is that through your outbreak, while you're managing the outbreak, you try to find a source. I think we discussed this before with some of you. It's quite rewarding when you can find where the problem originated, but quite often we don't find that, and it's something that just kind of appears and we have to deal with that. But it's interesting if you can identify these contributing factors and do create reports after these outbreaks. Usually we do like a debriefing note, we have a meeting with our outbreak management team and share the findings, but also if there was something that could and needs recommendations for improvement, this is what we would, this is a platform to deliver this news. So this is an example of line list. This is, I think, from Toronto Public Health. It is a very generic line list. I have uploaded for you guys in week 4. I will copy them also for this week, so you have access to that. But what you want to have in your line list is, of course, your demographics, the patient's name, hospital number, date of birth, the date of admission, and then the date of admission to the particular unit, and then under there is entire field under symptoms. So these symptoms have to be in line with your case definition. So if you're dealing with respiratory outbreak, of course, that will be fever, respiratory symptoms such as cough, shortness of breath, and so on and so forth. But you also want to include your laboratory findings, whether your patient has been tested, and how many times did you test them as you're going through this, usually the point prevalences. Then you can say when were they positive. And also you want to include the date of recovery, or if they didn't recover and sadly they have passed away. And also you want to include if there is any treatment. So some of most of the times it's self-limiting. If you're dealing with C. diff outbreak, there will be some antibiotic treatment included. You want to document that as well. And then any other important information that could be, such as, is your patient, have they been to ICU, or are they on any treatment such as chemo, or if they're dialysis patients. So anything that would have any significance for you to take a look outside of this particular unit, you want to include that, and it's easy for you to scan through. So those are kind of typical headings. You may want to include anything else that does have important impact on your particular outbreak. So that depends on you what you want to, but those are basic things that you want to have on your line list. So generally speaking, these line lists are for you, but also your public health unit will be asking you for either with reporting with every new case. You send in an updated list, or if there is no new cases, they would be usually asking you towards the either midweek or end week reporting, however you agree with them to share the information. But definitely any new case, you have to let them know. So here's the references. I don't know who was asking you about the definitions. So those are your references where I was pulling your definitions from. So these 3 last ones here are for the long-term care and acute care definitions that have been set for us. So I'm gonna wrap it up here. Is there any questions before we part ways? So tomorrow we will meet at
No
10:30
question.
Toronto time. Yeah.
No, I said no questions.
Oh,
Straightforward.
straightforward. That's good. I'm glad. I
Yeah.
always worry how am I giving you enough information that you need, or am I telling you what you already know and I'm just beating it to death? I don't know.
It helps to refresh.
That's good. Yes, so PHO has amazing resources that you can access, and a lot of them are free. I have also been looking for some courses and webinars that I can share with you guys. So I will be sending. This is what, when I send you these webinars, that's not mandatory. I'm just sharing what I come across and what's sent to me, so you can use or don't use. I just want you to have access to that. I don't know how many of you actually get emails with the trainings and stuff like that. So I just share.
Have you seen the new line list, Cornelia?
A new line list?
Um, the one that they used during COVID, it's electronic and you could pre-populate it,
Oh yeah.
basically with your resident names and staff names.
So I think that's probably something that's being created for the long-term care facilities. In acute care settings, we did not get
Okay,
anything like
I think
that.
it's for retirement and long-term care. Yes.
Yeah. So they're trying to support you guys because they know there is not enough resources. So they're trying their best. And I think it's really cool because it does for them it's easy to take a look at what's happening. And if you're entering this, it's probably feeding somewhere in real time for them, right?
Yeah, yeah, it does.
That's pretty cool. I think with the changes that we are seeing, that ministry is pushing for the standardization using the patient records and softwares. I think at some point in future we will be on a same platform and being able to see on the history of our patients and whether they tested and when did they test and what type of tests were they used to test them in the past for either COVID or anything that is of any significance to us as IPAC. So, Kareen, I uploaded templates for you. So if you are um, entering at the front where it's your um, line list that contains your patient information, diagnosis, and then at the back, it will be producing these pivot charts and, and tables that are automatic. If you need something more specific, you just filter it through so you can see. It takes some time to get comfortable. I don't know um, how I would say what would be your expectation for the level of expertise. I It's really hard for me to say that because I don't know how comfortable some people are. I'm sure some are more comfortable than others, and I'm sure there's some magicians in the group that can just whip up anything in Excel. I'm not that good, so it takes me time to get familiarized with the platform and looking at where are the things playing around, but that's all there is really. To once you get to know where things are, you can filter it how you want it and need it. Night, Anika. Good night, Marina. So tomorrow 10:30 we will continue, and I just want to say thank you guys for joining, and send me any emails if you have any questions, or we can continue tomorrow.